Hey everyone, it's really awesome to see people who don't have masks on their faces. It's very exciting to see you guys smile and see your facial expression. So as Abby pointed out, I am currently a bedside nurse. I predominantly work right now in the ICU, taking care of COVID patients. And after I graduate, I will be an outpatient private practice psychiatric provider and begin working on my DNP, which is a doctorate level nursing degree. Today we're going to talk about seasonal affective disorder. I'm going to go ahead and get right into it. If you have any questions, please interrupt me. I'd like this to be as interactive as it can be. It's kind of hard when we're not all together, but I find that things are more fun and knowledge sticks a lot better that way. So I am going to share my screen. You guys should see some slides pop up in just a second. Can everyone see that okay? Yeah. Okay. So when we talk about seasonal affective disorder, the first thing that I'd like to do is kind of go back to basics and talk about what these words mean. So when we're talking about this, seasonal really means that it's inconsistent. It has a really large role within the part of the year that you're in. When we talk about affect here in psychiatry, we're talking about an observable state. So someone's observable mental or emotional state. And when we talk about disorder, it's just a lack of regular, like a deviation from normal, okay? Let's see. And let me move my notes out of your way. So the secret about SAD is that it is not a real diagnosis. And what I mean by that is that it is not in the DSM. So it's not in the Diagnostic and Statistic manual for diagnosing mental health or psychiatric disorders. What it is a mood disorder that has a seasonal pattern, and the mood disorder type is depression. And we really see it most impacting patients in January and February. So we're right in the midst of when we would start seeing this pattern be exhibited in these patients. And in order to talk about the basic concept of depression within this disorder, we first need to talk about depression, right? And this is per DSM-5 criteria. So the Diagnostic and Statistic manual, which I'll talk about here in just a second so that we all know what that looks like, gives us criteria for diagnosing people with a specific disorder. And in order to meet the criteria for major depressive disorder, which is the basis, the basic mood disorder of SAD, you have to have 5 of the items that you see on your screen, and at least one of them has to be the underlined ones. So for 2 weeks, almost every day, you have either feelings of sadness, hopelessness, or feeling like emotionally empty, or a significant loss of interest in something you used to enjoy doing. So this cannot be someone who always is very negative, like consistently, that's a personality trait. And it cannot be someone who has never liked gardening and now we notice that they don't like gardening, right? This has to be a deviation from their previous behavior. So in addition to at least one of those 2 traits, you have to have a significant change in appetite. And it can go up or down, but within 1 month, it has to be significant enough that it would change your weight by 5%. Insomnia and hypersomnia just talk about sleep quantity. So when you're showing insomnia, you're sleeping less, and hypersomnia, sleeping more. And this isn't per a baseline that is set by an American association. This is per your baseline or per the patient's baseline, because every person is different. So if I normally sleep 6 hours a night and I've been doing that for several years, and then all of a sudden I'm requiring 8 or 9 hours of sleep a night, that's a big change for me, whereas that may be normal for other people. So the next one is being noticeably restless and or lethargic. So lethargic is just someone who their musculoskeletal behavior is slowed, it's diminished. They may be drowsy, and you can actually physically see that in their appearance, that everything that they do feels very slow. And again, that's according to the patient's baseline or your baseline, not the people around them. So feeling fatigued is a pretty common one. Feeling guilty or worthless. This is a feeling that doesn't actually have a emotional trigger. So an example would be if you feel guilty because you went gambling and you lost a significant quantity of money that your family needed, that might be a trigger that would lead the average individual to feel guilty. This patient or this person would not have a trigger to feel guilty. It would just be an emotional state for them. The next one is the inability to focus, and also that can come with the lack of ability to make decisions. And then the final one, which most of us have heard of, may be thoughts of death or suicide. So it's not necessarily a thinking of, I want to hurt myself, I have a plan to hurt myself, I think I'm going to commit suicide. It can be strictly the thought of passing away, or thinking that maybe it would be better if I weren't here anymore. Before we move on to how this relates to SAD, does anyone have any questions? No, okay. Let's see. Oh, before I move on, I did want to talk briefly, just because I want to make sure I'm covering like the biological basis that you guys are interested in, and some things that we rule out when we're looking for these signs and symptoms. So in patients that have symptoms that look like this, so again, 5 or more, and at least every day for 2 weeks, almost every day for 2 weeks, and it has to include at least one of the underlined, I want to rule out hypothyroidism, because hypothyroidism can really cause a slowing and a general fatigue within patients. Blood sugar issues, okay? A viral infection, specifically mono, can cause patients to become very, very lethargic, very tired very quickly. And then this should not be related to a pattern of substance abuse or grief or loss. So if you're seeing this type of behavior pattern, but it's around alcohol consumption, or it is around specifically the loss or passing of someone or something in your life, this probably will not come back to MDD on its own. It's probably related to the substance or the loss, okay? So what is the difference between regular depression, which we just talked about, and SAD? So for SAD criteria, you have to have depression symptoms, the ones we just talked about, but they are going to only occur in the wintertime, and they are going to resolve in the summer. Specifically, as the days get longer, you'll see resolution. As the days get longer, you'll start to see resolution of the behavior and or feelings and mood disturbance. And you will see it start to come on either early fall or late fall, like November, December timeframe. So like I said, this is not a DSM-5, and I'll talk about what that is in a minute. This is not a DSM-5 criteria, so a psychiatrist would not diagnose seasonal affective disorder. They would diagnose depression with a seasonal pattern or something that sounds very similar to that. However, most people do want symptoms to occur each year for at least 2 consecutive years in order to diagnose this. Some other things it's important to note are that the symptoms can last 5 months out of the year, unfortunately. Onset is usually in adulthood, averages between like 18 and 35. It's fairly common in American adults. It's like 5% of the population or more. And women are affected twice as much. They make up about 70% of the population diagnosed with something like SAD or similar concept. And there is a geographical indicator. So the further you move away from the equator does increase your potential. And so someone who lives in Florida, for example, would have significantly less potential for this compared to us, because we live in Virginia or wherever you guys may be. Now, I keep talking about the DSM-5, so I just want to make sure we know what that is before I move on. And the DSM-5 is a book, and there's an electronic version. And basically, it is created, this is the 5th edition that we're on, which is why the 5 is on the end. It is created to form a diagnosis around a set of symptoms. And the reason we need that is because it helps us to form treatment options and algorithms. The other thing we use it for is insurance companies use it for billing purposes. Hospitals use it in order to research data. Like, for example, if I fall within a depressive subtype and someone else falls within an anxious subtype, we would not be in the same group, depending on the data needed. Okay? Let me see. Sorry, I have some notes in front of me. All right. This is a gray area that I'm talking about here. This is from the National Institute of Mental Health. It is not in any of the textbooks that I utilized to create this, but I did think it was very insightful and helpful to know about, so I am going to talk about it. And what the NIH says is that there are different types. So the rare type is the individuals that you see symptomology in the summer. And so when we looked at those criteria, I'll go back just for a second. When we looked at these criteria to meet depression criteria, these people would suffer one of these in the summer. And then when you see this hypersomnia or insomnia, they would feel less inclined to sleep. They would feel more restless and anxious. They would be a little more frantic when it comes to making decisions. Okay, and that would be the summer patterned patients, which are a lot less frequently seen. Then you have the winter pattern patients. So these are your traditional patients when you think of this winter blues type of diagnosis. So these are going to be your patients that sleep a lot more. Weight gain, specifically, the NIH attributes it to craving carbohydrates. And there is a correlation between, I shouldn't say the word correlation, but there is some research that suggests that carbohydrate intake does have an impact in the brain on serotonin. And I'll talk about serotonin in just a second. So keep that in mind when I go to that slide. So weight gain and social isolation. These are going to be the people who kind of don't reach out as much. They may kind of be a little more distant this time of year in the winter time. And then in the summer, they become a little bit more socially engaging. So why do we think that this happens? We don't know. That is the straightforward, honest answer about almost everything within psychiatry these days. And before I move forward, I just want to kind of talk really quickly about psychiatry versus psychology. So psychology is the study of the brain and how the brain works, and therapeutic, non-medicinal, non-pharmacological interventions. Whereas psychiatry is a specialty that takes into account the pharmacological interventions, okay? So When we talk about within psychiatry and psychology, why we think this happens, the first one is a serotonin-based concept. And it is that the serotonin in the brain acts as an antidepressant, and that's simplifying it. It's very oversimplified, but there are books and books and books that talk about the impact of serotonin. So we're not going to dig too deep into that. But serotonin is the neurotransmitter that most antidepressants work on, and they're usually working to increase the quantity of serotonin in the brain. So when we know that that's how antidepressants work, we can see how if less light means less serotonin production or less available serotonin, that could lead to depression. The second one, which most of us have heard of, is called melatonin. So melatonin is something produced in the brain naturally at nighttime for most of us. As the light, the external light source decreases, our body will start producing melatonin in order to prepare us for sleep. And so some experts are recommending, or I should say suggesting, that in the wintertime, these patients are overproducing melatonin, which is causing some of the sedation impact and causing kind of a slowed, low-key pathophysiological process. So sedation just meaning lethargy, less likely to go out and do this and do that and play sports and everything else, right? And let me move this a little bit. And then I'm going to talk about vitamin D just for a second. And I put it in separate marks just because the two primary concepts are serotonin and melatonin when we talk about what we think is going on with this process. But vitamin D is what we call serotonergic, which means similar to antidepressants, it helps to boost the serotonin in the brain. And so the thought process behind this is in the summertime, there's a lot of sunlight. And when the sunlight touches our skin, it helps our kidneys activate a good part of vitamin D that we can use in our body. And in the wintertime, when there's less sunlight available, our bodies have a harder time converting non-active vitamin D to active vitamin D in our kidneys. Let's see. Any questions? No? Okay. All right. So with what we just talked about, let's talk about our treatment options. As someone with a nursing background, I advocate to utilize non-pharmacological interventions if it can potentiate healing to the level that we want. So I don't recommend going out and getting a pill as your first choice, right? But for this disease process, that is a possibility. And so what we would use would be an antidepressant. So you've heard of SSRIs and SNRIs, and those are traditional things like Zoloft, things that you've heard of. And when you are talking about that with your provider, generally what we are going to use to make a recommendation on a medicine is going to be the side effect profile. Some really common side effects of taking an antidepressant are going to include mania, increased appetite, anxiety for some patients, sexual dysfunction is not uncommon. And so it's a big decision to choose to take a medication. And it definitely needs to be discussed with whoever's overseeing your treatment. In addition to that, cognitive behavioral therapy, which is usually called CBT, is the best kind of therapy for this disease. It's also called talk therapy. And the goal of CBT, when you're meeting with your provider, is to, first of all, help you improve your internal dialogue. So it helps you find out, are you saying negative things to yourself about yourself or about your circumstances, and maybe you don't realize it, which can contribute to depression. The second thing it helps to do is increase the resources and coping mechanisms that you have on your own. without an external resource, so that when you do start to feel down, overwhelmed, sad, you have something to look at and go to for support, regardless of what's going on around you. That is not specific to SAD. That is just basic depression treatment, right? However, if we come over here and look at phototherapy, that's what a lot of people recommend, especially holistic providers, for people who are having depressive symptoms in the wintertime. So I just wanted to clarify a couple of points about phototherapy. And phototherapy is kind of exactly what it sounds like. You get a big light and you sit it on a desk, and you can buy them online for anywhere from, I think, $50 to $250, depending on what you're looking for. And it just promotes the sensory impact that sunlight has in the summer hours, in order to promote a more natural like circadian rhythm or day-night rhythm. So there are a couple of things to know. The first thing is, usually we recommend it before sunrise or after sunset. So what we're trying to do is, as the daylight hours start to slim down in the wintertime, we are artificially, telling our body that that's not the case. That instead of 6 hours of daylight today, I actually have 7 hours. But one of those hours was artificially manufactured by a light source. We've been using it since the 1980s, really for sleep disorders. You do not want to put it directly in front of you. So you want it to be off to the side. Generally, when you're talking about the most, I can't think of the word that I want to use, but the strongest evidence source, it's 10,000 lux or better. Definitely ultraviolet free. This is not a light source that you are going to get a tan. Okay, it's not going to have any of that kind of impact. If it does, you are really increasing your risk for skin cancer. So you want to, if you choose to go out and purchase one of these items, you want to make sure that it is UV free. And then the recommendation for how long to use it is going to be dependent upon the strength that you purchase, your manufacturer guidelines. So for example, if I purchase a 5,000 lux light source, I might need a little bit longer than if I purchase a 10,000 lux light source. And the second thing you need to take into account is your provider recommendation when you're looking at something like this. I'm also just briefly going to talk about two things, just because I have a note down here to mention them. One is omega-3 fatty acids. So EPA, DHA, that's like your flaxseed oil and fish oil and rosehip oil and stuff like that. It does show positive correlation when it comes to, let me say this right, because research and evidence it's important to verbalize it correctly. So it does show that in locations where people eat more fish, they have less depressive symptoms. The second thing is vitamin D3. So there's vitamin D, you can buy as a pill, but there are two types. There's vitamin D2 and there's vitamin D3. Vitamin D2 is a plant-based, like a vegan alternative. Vitamin D3 comes from animal sources, but vitamin D3 is significantly better metabolized by the body. And so when we're talking about the serotonergic, remember the antidepressant boosting impact that it has in the brain, the one that's going to be a lot better, if that's what you're using it for, is going to be the vitamin D3. So these are some things that I used for today. The primary thing we talked about was the DSM-5, just because that is really the driving force behind a provider giving anyone a diagnosis as far as mental health goes. And then the other thing on here is, I just wanted to mention it, is that suicide is a very real risk for a large portion of Americans. The latest statistics in America show that about 130 people die every day of suicide. Males are a lot more prone than females. Females generally have more attempts, but males have more success with suicide attempts. So if anyone is ever feeling sad, or if you have friends that ever feel sad or down, this is a great number to store in your phone so that if you ever need to, you can call and get help instead of making a rash decision that you can't take back. Okay, sorry to end on kind of a sad note. I will open this up to questions or anything else Abby feels is helpful. Let me exit.
I had a question, Callie. And also feel free for all of our participants. I wrote in the chat that you can wave your hand or you can pop your questions in the chat, but you can also unmute yourself. I was just offering to unmute you for those who don't know how to unmute, but if you do, feel free to unmute yourself. But I do have a question just to kick us off, get us started. If you go to your biological underpinnings slide, I think you mentioned serotonin, melatonin, and vitamin D. So I thought that was really interesting, especially the melatonin part about how they think some people might be overproducing melatonin, or the serotonin was less serotonin with less sunlight. Can you explain that connection between the sunlight and serotonin? Is it just that if I go out into the sunlight, my body makes more of it? And also, I guess a follow-up question after you explain that would be, if those three are kind of three of the biological underpinnings, I guess there's no way for your doctor to kind of check those things, right? Like, would you be able to go to the doctor and they determine for you that, oh, you're making too much melatonin? Or is that possible?
Abby, that is a really cool question. So, and it really is, like you're saying, not something we have a lot of actual evidence base about, because it's really hard to test the levels of these items, and it's really hard to see their impact in the brain. So the way the brain works is there are cells with space between them. And the way that the brain sends signals is cells send, I think of them in my mind almost as like floating boats, but it is a neurotransmitter, of which serotonin is one, norepinephrine is one, GABA is one. So there's several of them, and each cell sends one to the next cell. And that's how we have seizures. That is how our thought processes pass through. It is really, really cool. But what makes it so challenging to study is the fact that we really can't take a piece of your brain out and test the levels within the brain the way I could take some of your blood and test how much calcium's in your blood. There are several imaging studies that we're currently looking at to try to figure out, are there different levels of activation in different parts of the brain that utilize more of a specific neurotransmitter than others. So an example could be dopamine. So in ADHD, people who have hyperactivity and inattention on a clinical level, we have noticed that there's different levels of dopamine in their prefrontal cortex, which drives behavior. And so we're able to kind of figure some of that out by stimulating the brain while we do imaging, but there really isn't any specific way to differentiate which one is the cause over the other, which is kind of one of the things I love about psychiatry, is a lot of it is just a gray mishmash of questions. Yeah.
Yeah, that's interesting. And that does, oh, shoot, I don't know if it's picking up my voice.
I can hear you.
Okay, good. Yeah, great. Thank you. That does explain about the melatonin and just being able to test for that. So how about the serotonin with the sunlight connection? Is it, how do those two go together?
So we're still not, so much of this is gray. We're still not 100% sure. What we do know is that things that boost your serotonin are things that generally make, so things that you love. Like, Abby, I have a feeling you love books. And so for you, when you walk in and you're surrounded by books and there's all these great worlds and opportunities to experience these books around you, for you, that personally causes your brain to release serotonin. For someone who is like a mechanic and they walk into the shop, and for them, like being around cars and smelling engines and, you know, things like that, that is something that for them may promote the release of serotonin. And so it's different for each person. Really, things that we know for everyone release it is just happy experiences, building happy memories. Anytime you're stimulating a part of your brain that feels pleasant. And so that's part of the problem as well with drugs that creates an addiction behavior or an addiction pattern. So the clear answer is we're not 100% sure. But the like helpful answer is that almost anything that makes you feel good, if it's going to the gym and doing yoga, or if it's talking to your best friend on the phone, or if it's petting your dog, that makes you feel good, it's promoting the release of serotonin in your brain. And some other things come into play. So dopamine and norepinephrine are two other big ones. I'm not going to go too far into that rabbit hole because they're not quite as relevant to depression from this perspective. Does that kind of answer your question a little bit?
Yeah, I think it does, especially because, yeah, the sunlight thing. Okay, I'm gonna because sunlight is pleasurable and it's nice, and so I see the connection there.
And there's also the vitamin D. Like, let's remember the vitamin D right here. So vitamin D is in the kidneys is converted to a usable. It's called OH, but the short-term impact, or the short story impact, is just that vitamin D in its active form allows your body to transmit serotonin signals in the brain. Carolyn, did you have something?
I did. On the idea of light, we don't open our front draperies, they face south because there's just a lot of sun coming in. And this light, the lux, is that something that you just do? I'm under treatment for actual clinical depression. Do I need to get some light into my system? I mean, I can sleep 10 hours a day, and in fact do, but can I get some of these lights and just try them on my own?
So, Carolyn, I obviously can't make a treatment recommendation not knowing like your circumstances. However, if it is a non-UV light and it is not increasing your risks of skin cancer, I have not seen any studies that show it to have a negative impact. All I have seen is that it has a positive impact on people who really have seasonal pattern depression. And there are some studies that suggest it could benefit people who have general depression that doesn't have a seasonal component as well. That just hasn't been as well studied.
So I could study it for myself.
Yes, ma'am.
Oh, that was my mother. What, I know you can't really recommend all the way from 5 to, what was that, 10,000. What would you suggest perhaps in the range of, or would you?
So the psychiatrist that I work with, that is like my teacher currently, he prefers 10,000 lux or better. And that is his baseline preference. And I trust him implicitly.
Okay. And you're working with UVA?
I go to school at UVA. I have a medical attachment to the military as well. I do teaching and medic things there. And then I am also working with several outpatient providers in the Charlottesville area.
questions. Anyone else have questions or follow-up questions? Okay, we have something from the chat. Here are some phototherapy lights on Amazon. Mine is being delivered this weekend. Awesome. That's cool. And then there's that link in the chat, which hopefully everyone can see.
And this is a non-medical recommendation, but I do like to always put it at the end of anything that talks about mental health. The first thing is reach out to a provider that you trust. The second thing is let your loved ones know that you're struggling. It's great if you have someone who can just check on you once a week or twice a week and just see how you're doing. And the third thing, which I've already talked about, is a patient of mine actually said it, and I'm stealing it from him, but he said I could. Pills don't teach skills. And so the first line is not always going to be a tablet. It may be, we need to start therapy and start trying to maintain a really normal routine, especially in seasonal affective disorder, and especially in depression. We can really get caught in a hole where we are not waking up at a similar time every day. We're not maintaining a very good routine. And especially in our current environment with the coronavirus pandemic, a lot of people have found that it's creating depression just by eliminating a lot of their basic lifestyle. And they're adapting in ways that maybe aren't super positive. So things that we can do even before an appointment with a provider would include trying to start waking up at the same time every day. If you have pets or you eat breakfast, trying to get a same time frame to do that. Just trying to create a structure within life so that as things change in our environment, we still have like a pattern of behavior that keeps us consistent. And it has two benefits. So the first one is when you have a pattern of behavior that's pretty solidified, it's easy to recognize when something's falling, right? It's easy to recognize when you're not feeling right and things are changing and you don't know what to do. And the second thing is it's good for humans. A long time ago, I'm not going to get on a soapbox, but a long time ago, we had to go hunt for our food, and we had to kind of be a lot more physically active and a lot more engaged with society than we are now. So it's really important to promote that kind of engagement and that kind of pattern. And I think that's all that I wanted to say about that. Yeah, sorry guys, sometimes my brain takes off and I don't know where it's going. But the first thing is definitely starting to take care of yourself, finding a provider that you trust, and telling people that love you that you are struggling.
Yeah.
Any other questions that you want to put in chat, or if you want to unmute yourself and ask? Cool. Okay, well, thank you all so much for coming, and hopefully this was, helpful and informative. Thank you, Cali, for being here. And as I said at the beginning, this recording should be up on YouTube sometime next week. So yeah, thank you. I'm going to stop the recording now too. So if you want to